It is essential for the proper understanding of the lumbar paravertebral block that the anatomy be studied separately. The weakness of this block lies in its strength. Because it is such a relatively easy block to perform, because anesthesiologists are used to doing lumbar epidural blocks in this area, and thus placing needles at this level, and because it is such a relatively successful block, it is also performed by relatively inexperienced people for questionable indications. If a proper continuous femoral nerve block is performed with a catheter on the femoral nerve, and the lateral cutaneous nerve of the thigh and obturator nerve blocked, there are very few good indications left for the psoas compartment block. Hip replacement surgery, for example, because of the destruction of the joint capsule and therefore denervation of the hip joint by the surgery, is remarkably pain-free and therefore not a good indication for this block. Epidural block is a better choice for intra- and post-operative analgesia since patients become very uncomfortable if the down leg is not anesthetized and if the torso of the patient is not blocked. The psoas compartment is a relatively large and vascular compartment, and large volumes of local anesthetic agents are necessary to fill this compartment. This brings the whole issue of toxicity of local anesthetic toxicity into the equation. More so because it is such a vascular compartment, which also predisposes to retroperitoneal hematoma formation if blood vessels are injured. A large volume of local anesthetic agent in the vicinity of the epidural space is also potentially problematic, and many cases of wide epidural spread have been reported. Other problems like intra-abdominal placement of needles and catheters, kidney and ureter injury, and subarachnoid injection have also been reported frequently. Two very important principles apply with this block. A. Because the nerve roots are covered with dura, sharp and/or thin needles should not be used for this block. Even 22-gauge B bevel needles should not be used due to the danger of dural penetration and subsequent large-volume subarachnoid injection. As a general principle, large-bore TUI needles, 16 to 18 gauge, should be the best choice here since these are the least likely to penetrate the dura. B. The indications for this block should be carefully selected. The principle of the higher the indications, the lower the complications, and vice versa, applies here. Inguinal hernia, total knee replacement, iliac crest bone harvesting, and total hip arthroplasty are commonly selected indication for this block but are poor indications. Field block, femoral nerve block, and epidural block are much better and safer alternatives. Almost all local anesthetic agents known in various concentrations, volumes, and combinations have been used for this block. This author's choice is to use 20 to 40 milliliters ropivacaine, 0.5 to 0.75%, or 20 to 40 milliliters bupivacaine, 0.5%, as an initial bolus. This is followed by a continuous infusion of 3 to 10 milliliters per hour of ropivacaine, 0.2%, and a patient-controlled regional anesthesia boluses of 5 to 10 milliliters of ropivacaine, 0.2%. Large volumes of local anesthetic agent are generally required for psoas compartment block. It is, however, logical that a stimulating catheter, when placed next to the lumbar plexus roots, smaller volumes are required. This notion has, however, not been verified by research. With the patient in the lateral decubitus position and the lumbar spine flexed, a line is drawn marking the dorsal spines of the lumbar vertebrae in the midline. Palpate for the posterior superior iliac spine, mark it, and draw a line parallel to the midline from its midpoint. Palpate the iliac crests and draw the intercrestal line. The dorsal spine that is palpable on the line, which is marked here, is the dorsal spine of the fourth lumbar vertebra. 2/3 of the distance from the midline on the intercrestal line, as indicated here, is the point of needle entry. The second marking, made lateral, is where the catheter is anticipated to be tunneled. The skin is prepared with an appropriate antiseptic solution and the area covered with a transparent fenestrated sterile plastic drape. The area is now ready for the procedure to begin. The skin and subcutaneous tissue are thoroughly anesthetized with a lidocaine and 1 in 200,000 epinephrine solution. The subcutaneous tissue, where the tunneling of the catheter is anticipated, is also anesthetized. Note the slight medial angulation of the needle, and that the tissue, all the way down to the bony pars intervertebralis, or articular column, or transverse process, is anesthetized. In some patients, similar to the person in this demonstration, it may even be necessary to use a longer needle to reach the bony parts. It is, however, important only to inject local anesthetic agent after contact with the bone has been established. This is extremely important to minimize the theoretical but dangerous complication of intrathecal injection of local anesthetic agent. Again, note the slightly medial angulation of the needle to ensure contact with the bony structures. The nerve stimulator, set to a current output of 1 to 1.5 milliamps, a pulse width of 200 to 300 microseconds, and a frequency of 2 Hz, is clipped to the 100 millimeter insulated 17 or 18 gauge TUI needle, which enters the skin aiming slightly mesiad. The needle stylet is removed when contact with the bone is established. It is planned to walk off the bone in an inferolateral direction, as is indicated here. A loss of resistance to air syringe is attached to the needle, and the needle tip is walked off the bone in an inferolateral direction. If the needle is too short, a 15-centimeter insulated TUI needle can be used. In this demonstration, the needle length is marginal but just sufficiently long enough. The needle is advanced gently, and like in the case with the other paravertebral blocks, loss of resistance to air and the motor response, quadriceps muscles twitches in this instance, appears simultaneously. This recording demonstrated quadriceps twitching, which appears simultaneous with loss of resistance to air. The nerve stimulator output is turned down, and clear brisk twitches should still be present at 0.3 to 0.5 milliamps. It is important not to inject normal saline or local anesthetic agent through the needle at this stage, as this will make stimulating catheter placement impossible or very difficult. The notion of opening up the space with the saline for easier catheter passage is not based on scientific fact, but mainly on fantasy. In real live tissue, this in fact just causes tissue edema, which makes further nerve stimulation via the catheter difficult or impossible. The nerve stimulator is now attached to the proximal end of the stimulating catheter, and the catheter tip placed in the needle shaft. Notice the broad black mark on the catheter, which indicates that the tip of the catheter is now situated at the tip of the needle. The catheter is advanced beyond the tip of the needle, and the motor response should remain unchanged during catheter advancement. If, however, the motor response changes or the twitches stop, it simply means that the catheter is advanced away from the nerves, possibly into the psoas muscle or even intra-abdominal. Carefully withdraw the catheter tip to inside the needle shaft again. Make a slight adjustment to the needle, such as turning it 1/4 turn clockwise or counterclockwise, or advancing or withdrawing it slightly, and advance the catheter again. Repeat this maneuver until brisk motor twitches in the quadriceps muscles are observed during catheter advancement. The needle should never be manipulated if the broad black mark on the catheter is not totally visible, which indicates that the catheter is fully inside the needle shaft. With this recording, it is demonstrated that the catheter is advanced for 3 to 5 centimeters along the nerve, and the motor response remains unchanged during catheter advancement. The needle is now removed without disturbing the catheter. The catheter can now be tunneled subcutaneously by using a dedicated tunneling device or by inserting the inner stylet of the needle 1 to 2 centimeters from the catheter exit site to the previously marked and anesthetized spot. Railroad the needle back over the stylet and feed the catheter retrogradely through the needle. Remove the needle. The silicone tubing that protected the catheter tip during packaging is handy to protect the skin beneath the skin bridge. Clip the snap lock to the catheter and the nerve stimulator to the snap lock, and turn the nerve stimulator output up until a brisk motor response can just be seen. With brisk quadriceps muscle twitching observed, inject local anesthetic agent or, as in this demonstration, normal saline through the catheter. Notice that the motor response stops immediately upon injection of the normal saline. This constitutes a positive Roche test, which gives final assurance that the primary and secondary block will be successful. The catheter and snap lock are attached to the stat lock, which is applied to a convenient position on the patient's flank. The catheter exit wounds are covered with a transparent dressing to facilitate daily inspection of the site. Catheter removal is when the patient does not need the continuous nerve block any longer and after full motor and sensory function has returned to the limb. This is a sterile procedure. Hold the catheter at the proximal exit site and remove the distal part of the catheter from the skin bridge. Keep this end sterile and remove the entire catheter. Inspect the tip of the catheter for completeness and record this.